Welcome to the Academy of General Dentistry podcast series featuring Dr. George Schmidt. Each episode features experts in the field of dentistry who share insights and inspiration to help you succeed. Let's get started.
Hey, welcome back, everyone. We've got another fantastic show for you today as we welcome the one and only Dr. Michael Melkers to the program. Before we begin, though, make sure you subscribe to our channel, hit the like button, and ring that bell. That way, you'll be among the first to be notified of all things AGD. Hey, Michael, how are you?
I'm doing great, George. It's great to see you again. I know it's been years since we've been together, so I'm really looking forward to seeing you in Montreal.
It has. It's been quite some time, and really looking forward to chatting with you. So happy to have you on the program. We're very fortunate for that.
Thanks for having me.
Yeah, let me just tell the folks a little bit about you that may not know. So Dr. Melkers is a 1994 graduate of the Marquette University School of Dentistry and currently serves as visiting faculty at Rīga Stradiņš University in Latvia. As advisor and visiting faculty for the Pankey Institute in Key Biscayne, Florida, and lead instructor for RIPEGlobal. Melkers is an AGD master and holds additional fellowships in the International Congress of Oral Implantologists and the American College of Dentists. He maintains a private clinical practice in Hanover, New Hampshire, with a focus on comprehensive adult restorative care. Dr. Melkers balances professional time between clinical practice, teaching, publishing, and research. His mission is to help patients, teams, and clinicians realize what is possible and improve their level of patient care worldwide. And I said, as I said before, it's really, really a pleasure to have you on the program.
Well, thanks, George. I think my mom wrote that bio.
It's a good one. I like it. It's very short and to the point, so that's fantastic. So you're going to be with us in Montreal in July 9th through 12th in AGD 2025. So much looking forward to having you there.
Yeah, I'm really looking forward to it. It's funny because it's the first AGD I actually can drive to because I literally live between Boston and Montreal. So I'm packing up the Subaru, we got four hands-on going on. And, the drive I'm looking forward to because I was thinking lugging all that stuff on a plane would have been brutal. So Montreal is such a fun town, get there so often. So looking forward to sharing it with a lot of my friends.
Yeah, so that sounds like a good setup for you there because as you said, it's right near your house there, and so we're also hoping to see all of our audience there. And as you said, it's kind of easy for folks in the Northeast to get there, and even I think Air Canada is even given a nice discount for folks that want to book their flight through Air Canada. And we're looking forward to
easy flight, easy airport to deal with.
Yeah, no question about it. So speaking of AGD 2025, I think you have 4 courses you're going to be.
Yeah, they're not working me too hard. Only 4. And they're all hands-on. So got two that are 180 coded on occlusion, and 2 more that are coded. I think. Oh my gosh, I used to be on PACE. I should know this. Aesthetics. So we have a really interesting array of that there that we're looking forward to sharing.
Yeah, and there's a lot of occlusion courses out there, but anytime you can get a hands-on course, I mean, I think that's something you really should take advantage of.
Yeah.
And on that note, that's what I want to start talking to you about first, because in my experience in teaching at many different universities, I mean, I think a lot of people struggle with occlusion, and they have a hard time. And even some dentists that I know, seasoned dentists, just don't grasp that concept. I mean, why do you think that is?
I think it starts in school, and it's not the school's fault. And you and I started seeing patients sophomore year, and we were doing prophies. We actually didn't start doing restorative until junior year. And then you make 18 months and then you're out of Dodge. The one thing that is really missing from universities or education and dental school is failure. And occlusion really isn't appreciated, I think, until we start to see things breaking or be really inconsistent. As far as the dental profession, it's hard. I was just looking, I just hit my 31st year, but my first couple of years out, that's when Empress launched. That's when LVI got their occlusal philosophy. That's when Dawson got popular again. That's when Kois got started, and that's when Spear got started. And it all had to do with need. So just like anything, if we don't value the lesson, don't value the tool, we're just remembering canine guidance because that's the only thing we had to answer on an exam, and that's the only thing we frankly remember. So yeah, that's kind of my take on it.
So you mentioned a couple of things. You mentioned a couple of big names there, and I agree with you. That's about the same time that I got started there. And when you talk about Dawson had one philosophy, in LVI, if I remember correctly, was neuromuscular. So there's a
Hmm.
lot of different ways we can look at that.
Yeah.
And I mean, are you partial to one or the other? I mean, I remember Frank Spear would always say, "Well, they all work for some people, and some people they don't work for." So,
Yeah.
what's
Well,
your thoughts?
I used to teach with Dr. Spear. I've taken course. I've taken all of Dr. Spear's curriculum. I was personal friends with Dr. Dawson. I teach at Pankey. I've taken OBI. I've even taken LVI. And I bring that up not to, bolster my bio, but I've gone after, I think one of the things is when we only stick to one approach, and I agree with Frank on that, is we put on blinders. And if I can put everything together that I know in my approach in three sentences, it's how do you want it to look? How do you make it fit? How do you mitigate threats? Because occlusion is, you said people shy away from occlusion. That's like shying away from gravity. It's like, oh, I don't like that gravity stuff, so I don't pay
Right.
attention to it. If you're doing any level of restorative dentistry, you're doing occlusion. You're checking the bite on a single crown, and you're doing the filling. The unique aspect of the program that I'm doing, which is the equilibration session, everyone thinks equilibration means grinding teeth. It means finding a state of balance of opposing forces. So this is a really, really interesting exercise that I've been running for years and years. And the interesting thing about it is it's all about just a single tooth. Is actually help people experience restoring, reshaping, repositioning, removing, and replacing. So those are all the R's. Reshape, which everybody thinks, and I think you and I were both taught, or at least that's what we thought we heard.
Hmm.
Everything is grinding. So it's reshape, restore, reposition, remove, replace. And in just that 3 hour hands-on exercises, people are going to experience every single aspect of equilibration. Not only that, but how to talk to the patients about it and what the benefits and considerations are of each approach. I've had dental students and I've had prosthodontists do that exercise, and I will tell you, everybody walks away with something.
No doubt about that. Let me ask you this. So, when we talk about CR, I mean, CR for many people, it's easy to grasp if you're going to make a full denture, right? You're going to
Yeah.
put the patient in CR and restore them there. But I think a
Mhm.
lot of people have a hard time grasping the importance of CR and how that would, work in for maybe a quadrant of dentistry or, just, doing a bridge or a crown. So, how does that all fit together?
Well, when you look at CR, it's a problematic term, and it has a problematic history. I think the 109 years that definition has existed, that or that term has existed, that definition has changed 23 times, and everything related to it is clinically invisible. So we never know if we're in CR. The only way you know if we're in CR is you either dissect a patient, which I'm going to come out as opposed to. Do not dissect your patient's chairside. And the second thing is if you're going to CT or MRI image every patient, those are the only ways you absolutely know. What I think about CR, and you and I were taught the same term, comfortable, stable, repeatable.
Hmm.
And if MIP is comfortable, stable, repeatable, I'm totally fine with MIP. I think that pushing everyone towards CR, no pun intended, but pushing everyone towards CR for every single patient, it does not make sense. And it's a rubber stamp of treating everybody the same. I treat to MIP all day long.
I mean, to me, it always made sense for maybe a full arch reconstruction, right? And CR makes sense there because then you're gonna get the true hinge access and maybe take some stress off the ceramics and things like that. But
Sure. And
a
I think
lot,
that when I use the term CR, I actually switch it to apex of force. Is that's when the muscles are at their highest level of activity. Then you want a tripod, like you just said. You want your right, your left, and the teeth that are all supporting that. And the times that I absolutely use CR, at least to evaluate from centric relation, is when I'm opening vertical or when where I'm treating an arch or there's signs of instability. I will frequently evaluate from CR. That doesn't mean I'm going to treat from there. And even though these are hands-on workshops, I'm going to be talking a lot about that in, I believe it's the Friday morning program, which is the fundamentals of centric relation records, where we're going to actually be using a DFA instead of a traditional face bow. And then we're going to be using loose jigs, we'll be using leaf gauges, and I'll show my methods and methodologies and approach and workflow for actually verifying as objectively as possible where that patient's muscles and joints want to take them.
So let me take a sidestep here, just because I got a couple of things that you just brought up that I wanted to talk to you about. But talk to our audience about the difference between a traditional face bow and the DFA, as you said, and when do we use which one, and which one is, I don't want to say better, but more advantageous, and is there different? Talk to me about that.
Well, first thing I have to do is, being from a Jesuit university, I have to admit my sins that I was a big poo-poo naysayer of the DFA or the Quaspo. So the ear bow goes in the ears, and then we have a little fork that comes down. Now, that is actually based on average values, the distance between the auditory meatus and the condyle. The DFA, which is basically a fox plane with a striker stop against the centrals, is based on Bonwell's triangle from the condyle to the incised ledge. So both of them are based on average values. Now, I didn't want to use one. I hated it. I hated it like you shouldn't hate something. And then I started using it, and I realized the huge advantage of a DFA or a dental facial analyzer is that you also bring the occlusal or rather the aesthetic plane and the patient's facial midline. Whereas how many times have you taken an ear bow and it's cocked to one side, and then you decide to correct it before you do and then you're throwing average values out the window. So as one of the biggest naysayers of the DFA, I can say I have not taken a traditional ear bow in probably 5 years.
Yeah. What about as more and more people trend towards digital dentistry? I mean, how do you feel about digital dentistry and maybe things like array face and incorporating all of these things in with scans and so on and so forth? I mean, where are we going with that?
Well, again, digital dinosaur, analog dinosaur over here, 31 years in, is, digital isn't the future, it's the present.
Right.
And it's also the past. I mean, we're well into it. Scans are incredibly accurate. We can put things on an articulator. I think occluding, that is MIP, is insanely accurate. Where we lose the accuracy when we move to digital is motion. You have things like ModJaw, which are jaw tracking software that will actually get into the true movements. The problem is with some of the other digital software, it'll start with canine guidance at a certain angle, but then it'll keep going on that angle. It never goes across to crossover, that is to the lingual incisal. There was actually an imaging app a few years ago that actually got pulled off of the market because it was too good. And that is, I could walk by you, I could facially scan you, and then I could use that actually to break into your bank account. So
No
I
surprise there.
firmly believe jaw tracking is going to be a $5 or $10 app in the foreseeable, very near future. I'm actually kind of shocked it isn't. And I think once motion is incorporated with that accurately and not as expensively as some of the jaw tracking software we see out there, I think everybody's going to benefit, patients, clinicians, and technicians.
No doubt about that. The other thing you brought up was leaf gauge and Lucia jig. And, I've always used leaf gauge for years, and that's kind of my go-to.
Yeah.
Describe to our audiences, you think one is better than the other, different uses for different ones. When might I use a Lucia jig versus a
Yeah.
leaf gauge? And yeah.
Well, let's talk about when a leaf gauge won't work. A leaf gauge won't work in a class 3 where their mandible is ahead of their maxilla. And so if they bite on a leaf gauge, they're actually going to protrude their jaw. So the whole thing about a leaf gauge, and I'm like you, I use it the most, but it forces people to that seated position. And depending on how you use a Lucia jig, you can also force someone to a seated position. If you have them closed and slide forward, slide back, slide forward, slide back, you're basically enlisting the closure, the temporalis and masseter, the same way you are on a leaf gauge. Or you can just put the Lucia jig in, have them open, squirt bite registration, and have them closed by themselves. The thing about both approaches is regardless of that, when I'm done, and I'm right-handed, so I take the right registration and I trim off all the cut down to just cusp tip indentations on the right side. And with no hands, I just say open, close. Because no matter whether you use a leaf gauge, a Lucia jig, or bimanual manipulation, is we need the patient to be able to go there by themselves without it having hands on her face or leaf gauge.
Right.
Dr. Dawson actually changed his terminology from bimanual manipulation to bimanual observation and verification. And what Pete said is he said, if you have to jam or push or pull someone into CR, they're not there. They should go there by themselves without comfort. So whether we're using Lucia jig or leaf gauge, I still want at the end for me to not to be doing anything.
That's a great statement and something we should realize because I think almost anytime, I mean, anytime bimanual manipulation comes into play, I almost always feel like I'm half the time pushing someone into it. They're
Yeah,
not really falling in by themselves.
yeah. And I think that, yeah, I'll leave that one. I'll go deep down a rabbit hole. You can tell I'm not passionate about the subject at all.
I know I was going to say we could probably talk about this all afternoon, but that's for sure. So let me ask you this. So in when your patients come in, you're doing a new patient exam.
Yep.
Is this a part of what you do? In other words, you're obviously going to examine occlusal disease and all that. Are
Mm.
you checking everyone for this? And are you and we'll talk about it in a minute. Are you deprogramming and doing all these kind of things for every patient, or it's just sort of case by case, or how's that working?
So previous version of me, when I first started down this rabbit hole, everybody got two sets of impressions, Facebook, two sets of CR records, and I had a dent on my door, and it was not coming in. It was them leaving because I was treating everyone with a rubber stamp.
Yeah.
So I will evaluate, fremitus, I'll evaluate wear, I evaluate erosion and NCCLs and all that, but I'm not doing mounted models unless there's a reason. Now, before, when I was doing analog impressions, it was a lot more of a hurdle, but now I will frequently do at least a scan uh, if as part of my initial records. But am I doing a FACEBO or a COISPO or a DFA and CR records or even screening to first contact at my new patient exam? I'm not.
Yeah. Are you scanning everybody and printing models, or just scanning and holding it for a catalog if you need it?
Got a lot of them here. So I put them, I find that I take photographs on all my new patients, a 8 photo series, but I find that more valuable to really zoom in on things. But there's a wow factor of having the digital scans on the computer. I have my computer that I'm sitting talking to you, that's my 27-inch Mac. Then I have a 27-inch PC over here, and I can go back and forth between the pictures and the models of the patient, depending on how they learn. And some of them want to see photos, and other ones want to be wowed by me spinning their models around on that. So I think when I first got into digital, I was holding on to analog so tightly that I was printing everything. And it was absolutely ridiculous how much I was printing. I'm like, why am I printing this? Like, I think Dr. John Cranham and I were talking about, his and my relationship in learning. And his daughter was like, Dad, you don't, his daughter's a dentist. And his daughter was saying, Dad, you don't need to print it. You don't need, he's like, but I need, but I, he's like, it's like, Dad, you're a dinosaur. And John and I laugh about that because we're like, yeah, she's kind of right. So I love them on the screen. I love them for basic records. Uh, in my rehab practice, I print frequently. I might design digitally, but then I'll print, I'll mount, and I'll modify. So I kind of have a blending of analog and digital that allows me to actually work out those motion paths that I was talking about with you before.
Fantastic. Michael, we have to take a quick break for a word from our sponsor. We'll be right back.
This AGD podcast series is sponsored by DHP, one of the largest family-owned full-service dental dealers in the U.S. DHP provides dental and medical supplies, equipment repair, maintenance, technology, and equipment sales to clinics and practices nationwide. AGD members receive exclusive discounts and promotional offers when they buy from DHP. We are especially grateful for DHP's continued support of AGD. Their partnership helps make this podcast and the vital conversations we share possible. Discover why like-minded general dentists work with DHP by visiting their website at www.dhpsupply.com.
Welcome back, everyone. We're talking to Dr. Michael Melkers here. We're talking about occlusion and some other great stuff. And I want to pick up where we left off. So you said something really great before the break, and that was you adapt what you're talking to your patient about how, according to how they learn. And I love the idea that you're kind of integrating that and sort of morphing, if you would, your presentation. Can you just elaborate a little bit more on that? Because I think that's so important, because we can't give the same spiel, if you would, to every single person.
Right. So thank you. That was a big breakthrough for me when I was able to shed my need to be omniscient. And, you know, one of the biggest fallacies, I think, is that we have to educate our patients. Our patients need to educate us. They know more about themselves than we will ever know. And our job, if they give us the grace to, is to play catch up. So and I think this is in the equilibration exercise that I talked about, the communication aspect. I use a sheet that I call the 3 Ps. It's purpose, process, and presentation. First and foremost, why does the patient want this? And that actually is the treatment plan. Their goal of desire is the treatment plan. And then we can have a choice of process, and that process can vary widely. And then for each of those processes, we can have how it benefits the patient and what the considerations are. I used to say consequences, but I now say considerations, because I realize that we get into this values disagreement. Is if they do something that we wouldn't do, is it something we wouldn't do because we think it's the best for them, or it's our personal preference?
That's
And I
right.
think there's a huge value bias in case planning our patients. And it'd be like, you know, if say, you know, you have a upper first molar that needs a crown. And I said, you have a choice. And they said, well, what are my choices? And I said, well, you can do gold or you can do porcelain. And they'll say, what's the difference? And I said, well, gold looks like gold and tooth colored looks like tooth colored. And then I'll say gold is a very weak material, but that's its strength. It says if you apply a lot of forces to it, it will bend, it will mold, it will adapt. Now, the benefit of tooth colored is it looks like a tooth, it's very aesthetic. Now, porcelain, like the enamel, is an incredibly strong material, but that means it can be brittle. Now, with that brittleness, if you apply enough force to it, unlike the gold, it will break. And I know I even have my own bias when I say that word, because I still do 85% gold crowns on molars. There's somewhere in there, and I used to be a gold technician, but everything that is the first thing is the benefit, is why do they want it? So imagine if you broke a tooth and you broke number 14, or say, or the Canadians are going to say 2-6, and you were in pain. The next patient broke 2-6 and they didn't like it, how it looked in their smile. The next patient came in and wasn't able to eat. The next patient came in and whatever. And it is always money, aesthetics, function, and finances. And if I talk to you about aesthetics and you're like, dear Lord, I'm in pain, help me. But I'm talking about how beautiful it'll look and how great porcelains are. It's the same treatment we're talking about. We have to understand our audience, just like literally any profession, any entertainer, any doctor, any engineer, any waiter. You have to understand your audience so that you can talk to them in their language that is their values, not ours.
That is so true. That is so true. Nothing more true has been said this day, that's for sure. Um, so let me ask you this. So on all your bigger cases, excuse me, and maybe even your smaller cases for that matter, are you going to equilibrate all your patients prior to doing any restorations? I mean, are you going to look at the occlusion and balance the occlusion before you do any number of units, or are you just going to go, this is just for
No,
specific patients?
it's completely case dependent. I tell you, in an earlier version of myself, I equilibrated almost everybody. And as my good friend Dr. Gary DeWood says, he said, I've equilibrated thousands of patients in my career. Half of them probably needed it. The problem is I don't know which half. And when we rubber stamp malocclusion as a disease, I really think that's wrong. Is there tooth wear? Yes. Are there NCCLs and abfractions? Yes. Is there erosion? Yes. But thinking that we will cure something by correcting the way teeth fit together, I think is a fallacy. We tried to stop people from grinding by doing that. We tried to do it by joint position. We tried to do it by vertical dimension. The latest thing is airway. And I'll tell you, I'm working with some people in studies that show even airway patients that are addressed with CPAPs or mandibular advancements, they're still grinding their teeth.
Yeah.
So with the whole reshape, restore, when am I really equilibrating? When a patient sometimes has a functional issue, they say, when I chew, and I don't think teeth should touch when they chew, Lundin and Gibbs showed that, but they said, I'm hitting here, I'm clonking on this. Yeah, we can look at equilibrating. I certainly equilibrate if there is instability in the bite when I'm restoring quadrant or an arch. And I consider a full mouth a rehabilitation is an equilibration. A full arch is an equilibration. Whether you equilibrate that to, a muscle guided position or a CR joint guided position, I actually have it's difficult to get into in this just a podcast, but I have a methodology with appliance therapy that shows where and how people grind and what their range is, not only laterally, but also to a seated position.
Wow.
And that's that apex of force that I was talking about, is because you know this. You can force someone to CR, but it doesn't mean they go there. And sometimes it's because their muscles are holding them forward. And some people just don't function and live in CR. And
Yeah.
those might be the people that have the airway issues that are holding their jaws forward. I find that frequently in class threes, that we can get them back to a seated joint, but they actually don't like living there.
Yeah, no question about that. So I think it goes back to I think a lot of what you're going to talk about in your course. I mean, CR, you've got to understand when to use it, when not to, and a
Mhm.
lot of people function just fine. And what you and I would think is, oh my God, that's a terrible occlusion, and there's all kinds of interferences, but
Yeah,
they've lived like that for 50 years, and there's been no issues, and they've adapted and
yeah.
conformed to that.
So
So I think
well, you've seen this, right? You have this person that's a perfect class one occlusion, and and their dots are all in the right place, joints in the right place, and they have terrible facial pain. And then the same day you see this other kid come in, and he has a crossbite like every other tooth, has like this 5 millimeter CR MIP shift, and he still has malleolons and paracomata, no facial pain, and it's like you have no idea where his joint is, but he's happy. That goes back to let's not rubber stamp patients.
Yeah, yeah, I couldn't agree with you more. So let's shift gears here and talk a little bit about some of the other things you're going to talk about,
Yeah,
and that is provisionalization, because I know you got a lot of good stuff to talk about there.
yeah,
Um, so let's just say this. So provisionalization, I know we talked about printing models and all that. Are
yeah.
you are you are you printing some of your provisionals, and are you making the other ones freehand, or
Both ways, and we're going to be doing both ways in Montreal. So in the morning, we're going to be doing direct provisionals. And so we're going to be making matrices to make the provisionals. We're going to be doing reduction guides, uh, all different kinds, facial, uh, palatal, incisal reduction guides. And then we're actually going to be making a 2 unit anterior cantilever bridge that could be a direct one, or it could be that we're making a shell temporary. So some people that haven't embraced digital and printing yet, this is a comfort zone. It's also a nice comfort zone even for digital people when your printer breaks, because my printer just broke today.
uh
And I was like, I'm freaking out. So we're gonna be doing that in the morning, and we're gonna be playing around. Well, I'll get to the playing around part because it's morning and afternoon. Then the afternoon, what I have is I actually have some printed provisionals and printed models, and what I have done is I've had a bunch of crowns printed up. First of all, I designed them to fit, and then I made them too long incisally, and I made them too bulky facially. So I don't know about you, if you've ever had a crown, probably never happened to you or me ever.
okay.
Something comes back, you don't like the contours,
Yeah.
and you're like, well, what do I do? Well, this is where we're going to be playing around with length, with line angles, with contour, and really developing that. We're actually going to do that in the morning as well, playing around with contour and how we can make wide teeth look skinnier, how we can make long teeth look shorter and short teeth look longer and skinny teeth look wider. So we're going to be playing around with shape, contour, and then the final aspect in the afternoon on the printed crowns is we're going to be working around and playing with color. And I really, really like this tinting system that I use. And we're going to show you literally how to take a tooth that is gray and get it all the way through the A ranges. Now, you say, I don't want to do all that color. Good for you. If you hit A2 or A3, put a gloss on it, call it good, that's a good win. But when you have these really crazy messed up ones, and I think we might even pop an image in here. I talked to Kristen about that before. So when you have these really crazy mixed up ones, you can actually work not only helping your patients so they match, but you could also use that as a custom shade tab to send into your lab. So I know some people said, "Oh, you never want it to look good. You want the patient to come back." I will say as a former and current lab technician, boo. Give them your best work, wow them, and make them raving fans that send more people to you because you're not just a dentist, you're an artist, you're an engineer, and it's magic. It's
Yeah,
fun.
I read through a lot of the materials for the course, and I didn't know that. I didn't see that, and I love that, especially the staining and shading and tinting and all that kind of stuff. And I would imagine you're going to be doing this on PMMAs or acrylic or whatever material you might be using. But this would also translate to ceramics, right? If you're somebody that mills crowns in your office, changing the line angles and all that, you could adapt this for that, right?
Yeah, the changing the line angles, it doesn't matter. Is if you're doing direct composites, that works for that. If you're doing, provisionals, or if you're doing CAD CAM, or if you're just getting, a crown back from the lab that you want to change some things, it doesn't matter whether it's acrylic, whether it's ceramic, composite. I'll tell you, George, the interesting thing, and this was by not by design, but turned out really well. So Dr. Lane Ochi, he's my teaching partner, and and Lucas Lamont, my technician, we've done this exercise with printed resin, right? So it's supposed to be pretty already. And when I got my new printer, I didn't have the resin profiles, and I had a study club in this last weekend, so I actually printed the crowns out of model resin,
Oh, really?
sand colored model resin. I was like, it looks hideous. But you know what it looks like? It looks like the worst acrylic crown you ever did in your life. And I showed them how to add translucency,
Uh-huh.
how to add depth, how to add white decalcifications, how to add craze lines, pretty much anything that you need to do. And when we were finished, we took photos with my digital SLR and we put it up on a 4 foot television monitor and we looked at it and you turn it around, it's gray. You turn it this way, you swear to God, it came out of a lab. That
That's
I'm really, you can't tell I'm really excited about that one.
Yeah, no, I'm excited too. That's incredible. We had James Klim on the program last year, and
Oh
I
yeah,
don't
he's
know if you know,
awesome.
he does incredible ceramic work, and we talked a little bit about this for ceramics, but not
Mhm.
for composites. And
Yeah.
wow, I got to figure out how I can get in there and take that course.
Saturday, yeah, Saturday afternoon is the printed provisional, and
Uh,
Saturday morning is the direct provisional. And it's actually for some people, they do take both of those courses so they can
yeah.
kind of fill both sides of the road.
What do you think the biggest mistake people make when they're fabricating temporaries or provisionals? I mean, you've got a lot of experience in this. You've taught so many hands-on courses over the years. I mean, could you put your finger on one thing, or is it just a combination of different things that people kind of mess up? Or maybe the hardest thing to grasp, if you would, or the hardest thing to master that would make everything so much better. Maybe that's a better way to ask the question.
I guess there are a couple things that I think about because of my perio background and my technician background. I'm always thinking marginal integrity.
Hmm.
There's nothing that makes happier tissue than
Yeah.
well-fitting provisionals at the gum line. Now, when we talk about aesthetics and occlusion, our provisionals are really our aesthetic and occlusal blueprint. Is if I'm working on a full mouth rehab, I want my dots and I want my lines exactly where I want them in the finals. And
Mhm.
that's wonderful thing about scanning is scanning the provisionals, the approved provisionals, not only approved by me, but approved by the patient and say, Lucas, this is exactly where I want things. And the other one is from the aesthetics. I mean, George, you and I have both been there and you put in the smile or you put in the crown and the patient is not smiling. And we dropped the ball and they're like, oh, I didn't know it would look like that. Or I
Right.
didn't know it wouldn't look like that. So I think I like a coat of glaze and an A2 and make it pretty all day. But when you look at patients that are of high aesthetic demands, but not what you would consider a cosmetic patient that have all these kind of characterizations, I think that the tinting is absolutely amazing. Now, backing up between those two, I think that contour is also incredibly important. If we just go back to that A1 or B1 or whatever, and they look like chiclets, but we promise in the finals they're going to look better, there's a leap of faith. And I know that you and I have both done that where we've contoured a crown like we like it, but the patient's like, why is it so rough?
I know.
That'd be nice to know before we get to the finals.
No question about that. And we only have a few minutes left, but real quick. So I guess it would be depending on case. How long do you leave these folks in tempers if you're doing a aesthetic case? I mean,
Well,
is it,
how long have you and I been talking?
yeah, no, is it to work out the
No, no,
occlusion?
because
Is it
you've been looking at someone that's had a temporary crown on number 8 for 3 years.
okay? Oh, all
So,
right.
so I lost number 8 during COVID, and it's a printed crown. It is aesthetically contoured and
Uh-huh.
characterized, and people say, "Why don't you get the final?" And it's like, because I'm a human being,
Yeah,
and just like
yeah.
everybody else, I put things off. I during COVID had people in temporaries or provisionals for 5 years. I
Wow.
have some people, and unfortunately, this morning I had a patient who doesn't have a long life expectancy and or medically compromised, can't go through crown lengthening, can't go through extractions.
Hmm.
And I have them in long-term provisionals. And the longest one I've ever had was in Spokane. When I practiced there, he was my very first patient. We hadn't even finished unboxing. And I put him in a provisional that day. He was still in that provisional 12 years later because it was a periodontally hopeless tooth. And he said, well, maybe we can get a few years out of it. We got 12.
Yes, that's a great service for those folks because we've all had them. I've had plenty of people like that.
Oh, yeah. And
And
whether it's printed or bisacryl, I mean, we have the highly reinforced bisacryl today that
mhm.
it holds up incredibly well. So I think our options are so much different than when you and I graduated.
Yeah, and I know you're going to share your armamentarium when you do your course, but are you for staining? Let's just talk about staining. Are you using one kit, or do you have a whole little arsenal of things that you might use to make that just right?
I use one single kit. Are we okay naming brand names here?
Sure.
So I use So I've used a lot of different stain kits, and everybody has kind of their own preference. The one that really has the absolute wow factor for me is OptiGlaze from GC, and it has a lot of colors. I mean, it has to have like 20.
Mhm.
So it has all these different colors, but then it has an A modifier, B modifier, and a C, and that's just like A1, A2. The
Mhm.
more you use, the higher the chroma. So you're like 20 shades, that's insane. I agree. I'll use clear, I'll use an A modifier in most cases, and then I might use blue or lavender for
Mhm.
translucency, and then I'll use white for decalcifications, depending on what I want to accomplish. But just like joint position, I don't overly complicate things.
Yeah.
If clear gets us to the finish line, hurrah. But if you want those little subtle characterizations, I maybe have 5 colors that I use regularly, but that doesn't mean I use 5 colors all the time. But we're going to be playing around with 5, 6, at least 6 or 7 colors. And we just did a study club this last weekend in my office, and people that had no background as a technician, had no background at staining ever in their entire career. By the end of the 3 hours, I could not tell the difference between their work and mine. And I'll tell you, a couple of them actually look better than mine. So, like I
Wow.
said, the color, the color one is going to just be so much fun. We're going to have a blast.
Fantastic. And you know what? I wish we could talk about this all afternoon because I'm about as passionate as you are. Maybe not so much, but very close to this subject too. And it's really great stuff. But we're out of time. I just want to thank you so much for coming on the program. I really look forward to seeing you up in Canada. And I know you've got a lot more great stuff to share. So thanks for coming on.
It's going to be fun. I hope we can share a meal because Montreal is an amazing eating town, incredibly friendly people. So we'll see you, what, in just a couple months.
Yeah. Okay. I'm going to take you up on that.
All right.
I'd also like to thank our producer, Kristen Gover. If you like what you heard, please like and subscribe to our channel. You can always find us on the AGD app, Spotify, SoundCloud, Apple Podcasts, and on YouTube under @General Dentistry. If you have any questions, concerns, comments, or suggestions, contact us at news@agd.org. And Michael, before we leave, I just want you to share your contact information. How could people get a hold of you? Or maybe if they want you to come out and speak, how could we reach out and get you?
So my contact info, you can email me at my name, info@michaelmelkers.com. I think that's usually always going to be the easy first point of contact. And I guess it'd be okay. I'll share my cell phone, which is 509-868-7790. And you can just text me, call me, and I do master track programs all the time on a variety of these subjects. And thanks for the suggestion, George.
Excellent. Well, thanks again, and we'll see you next time.
Cool. Take care.